my name's Dr. Michelle Johnston. I'm one of the emergency consultants at Royal Perth Hospital. This is 5 on Friday and I get to talk to you about ketamine. Ketamine, pretty cool drug, a wonder drug, a very unique drug, and certainly has revolutionised a lot of what we do in critical care. So in this very fleeting 5 minutes, I'd like to tell you just 3 things about ketamine. First, how it works. I reckon if you can ever use a drug, you need to know how it works. Number 2, how and why we use it. And number 3, the bad stuff, the adverse reactions and how to deal with them. So how does ketamine work? Why is it unique? Well, ketamine is a NMDA receptor antagonist, and what that essentially does in the brain is it has this incredible ability to cleave the connections between the outside world and the brain. So what it does, it uncouples the brain from external sensory stimuli. What happens, the brain ends up being this little cocoon and it can't feel pain, it isn't aware of what you're doing, and it does not lay down memories. The second thing ketamine does is on the body, it has a mild sympathomimetic response. So it puts up your blood pressure and your heart rate a bit and maintains your airway reflexes. So this is why it's got these incredible uses in critical care. So the way we use it, the second point, is it's a dose-dependent response. It goes from analgesia to partial dissociation to dissociation. And at that point, that's when we start to use it for procedural sedation. And then there's this whole cornucopia of other things that we can use ketamine for based on the way it works. How we use it, the route of access is really either IV or IM or IO in those desperate situations. Don't do what we used to do in the late 90s, which is use it orally, 10 milligrams per kilogram in orange juice because it tasted like crap. That's about as useful as a philosopher at a Trump rally. So no, we use it mostly IV or IM. The spectrum of management or for uses for management, let's start with analgesia. That's very low dose, 5, 10, 15 milligrams max. And it's a very effective analgesic agent. It's opioid sparing where opioids no longer work or are contraindicated for other reasons. Very, very powerful analgesic. But beyond those doses, that's when we get into procedural sedation. That's when it really kicks ass as a drug. And we use it very frequently now for those reasons that I talked about before. That patient's brain is cocooned from anything painful or awful that we're doing to them, such as enlocating joints, straightening limbs, amputating things, anything, dressings, terribly painful things. It works briefly and incredibly effectively. And that dosage regime changes depending on what you need it for and how long you need to use it for. But it really has to be above sort of 40 to 50 milligrams, so you're into that proper dissociation. Because remember, ketamine is a dissociative agent, as we discussed before. The rest of it, and the dosage certainly changes for intramuscular use. Intramuscular use, it's about 4 milligrams per kilogram. It certainly is in the paediatric population, but adults is a little bit more variable. Look, the other massive cornucopia we can't go through today, but things like a sedative induction agent for rapid sequence intubation, incredibly effective where patients have either respiratory or cardiovascular compromise and you need to maintain airway reflexes and cardiovascular stability. Lots of other reasons, including infusions for analgesia. It's used to facilitate procedural sedation for non-invasive ventilation, and many, many other things which we just don't have time to go into. What we really do need to talk about, though, is the bad stuff, the psychic distress. What goes up must come down. And when patients are emerging from ketamine, we have this thing called emergence phenomenon. Because when you know how it works, if you've got this wonderful brain cut off from the outside world, it's all in a world of its own, having possibly a good time, and you start to get the recurrence of sensory input from the body, patients can freak out. We've all seen the galloping crazies that go on. There are 2 really effective ways to deal with that. One is psychological and one is pharmacological. And I think you need to have both when this is happening. Psychologically, it's a very interesting phenomenon. You can coach a patient before they get dissociated, tell them exactly what's going to happen. so the patient knows what to expect when it goes on. I actually tell them to have great dreams. Choose your own dream, choose your own adventure. Knowing when that patient is fully dissociated, you can't really get any more information to them until they start coming out, but a calming voice. Pharmacologically, most of these patients do need a sniff of something else, such as small dose propofol, small dose benzodiazepines such as midazolam. So that's the Cook's tour of ketamine. Lots and lots, it's a fantastic drug. There's lots of emerging evidence about really cool uses, but that's for another day. Thank you.